I'll be discussing a 35-year-old woman who presented with syncope. 35. She has a past medical history of known bicuspid aortic valve and smoking. Presented to the ED with 2 episodes of syncope as well as loss of consciousness with prodromal chest discomfort. Basically, she has been having intermittent dyspnea going on for a few weeks, but didn't really pay any attention to it. Doesn't really associate any lightheadedness, dizziness, chest pain, orthopnea, cough, swelling, or any other symptoms. On the night prior to presentation, she was having dinner at the dining table and just had a sudden episode of had some chest discomfort and then suddenly passed out. She had minimal 30 seconds loss of consciousness, got up, her boyfriend witnessed the episode, sat her up, and then happened right again within 10 minutes, again with loss of consciousness. Didn't happen the rest of the night, and the next morning, the day of presentation, she again had chest discomfort, but this time did not have any syncope. So they called their outpatient physician who recommended going to the nearest ED, so they came to Cooper. Of note, her last transthoracic was about 5 years ago, but she recalls her physician telling her that her AS was only mild to moderate. Her past medical history, as I said, known bicuspid valve. She smokes about a pack a day for the last 18 years. Also has significant anxiety. Social history, she's been, as I said, a 10-pack-a-year smoker, no other drugs or alcohol. Her past surgical history none, family history unknown, and she takes Toprol XL 50 as well as Boosterone. Her exam was mainly notable for 4 out of 6 late peaking systolic murmur at the right upper sternal border with a diminished S2. The rest of the exam was grossly unremarkable, no volume overload. Her vitals as well were also unremarkable. And this was her EKG.
So normal sinus rhythm, pretty normal looking voltage, maybe, borderline, but doesn't quite meet the criteria for LVH. Nothing that looks like an acute ischemic change, normal R wave, for a pretty normal looking ECG.
Yeah, normal looking, which is interesting because we're already given the history of aortic stenosis. So typically with aortic stenosis, we might expect to see LVH, right? That's one of the hallmarks, yet we don't see that. And I think sometimes, in a younger person, this is a 35-year-old, right? A younger person may not have the classic findings that you would see in a 85-year-old with senile calcific aortic stenosis. So it's something to keep in mind. So fairly benign looking ECG, normal conduction, heart rate's not fast, slightly bradycardic activity, but overall unremarkable ECG. Chest X-ray. So, but I'll just say that this is a fairly normal looking chest X-ray as well. You can see, the younger person, the bones look good, the bony thorax looks good, the respiration effort is good here. There's no effusions. The heart appears to be normal in size. So fairly unremarkable. What I'm not seeing is calcification of the aorta or the aortic valve, not clearly seen here. So that's what we're looking for, but I'm not really seeing. Okay, I think we can move forward.
Initial lab results, again, grossly unremarkable. NT-proBNP was 240s. Chemistry panel and CBC were unremarkable. And her transthoracics.
So the echocardiogram is there. I'll ask maybe Dr. Waldman to comment on the echo. Brett, if you're there, can you tell us?
Hi, Perry. I'm actually in the car, so I I can't see it that well, but it's all right. The LV function looks normal. The valve looks calcified in that short axis view, but hard from that view to say whether it's a bicuspid just on that view, at least here in the car. The walls don't look too thick, and the aortic root looks pretty normal in size in that short and the peristernal long, but again, it's not really zoomed in.
So we're looking for, obviously we know that there's pathology of the aortic valve. The question is it bicuspid or not? And if it is bicuspid, then the typical association is with the dilated aortic root. And so that's what Dr. Walton is looking for. Difficult to say it just these views. So, Brad, in general, when you're looking for a bicuspid valve, what are some of the clues on echo that it's bicuspid?
So you need more than one image plane. So we kind of use it all together, unless it's a slam dunk. The slam dunk would be more in the short axis view at the aortic valve level, which is your picture at the bottom left. That's kind of your best view to look and see in diastole and systole what the valve morphology is. You can also look in the peristernal long and see if there's any asymmetry of the line of closure of the valve in that view, or any bowing or doming. The other thing you can use is probably the fourth line would be your M mode and see where the line closure is. But typically we use all three views and place more emphasis on the short axis view there at the aortic valve level. Also goes along with age. If you have a 30, 40-year-old, 50-year-old, and it looks sclerotic, it's more likely not to be degenerative valve disease or senile calcific aortic stenosis, but more likely bicuspid. So age, and looking at those three
Right.
views,
So you can certainly see on the short
and then put in a context, like you said, with the aorta, and rolling it out. Say again.
I'm saying on the lower left image there, you can see that there is thickening and calcification of kind of one of the commissures of the valve, and you don't really see three distinct commissures. Typically, the aortic valve has, some people call it the Mercedes-Benz sign, but you can see the nice three commissures are like a peace sign, but you can't really see that here, and that's worrisome for a bicuspid valve. And I think this is what we're seeing here. Then on the Doppler, obviously there's some turbulent flow there. You can see on the lower right. So we'll have to explore this more. Why don't we move forward with some additional? Brad, maybe we'll get somebody else to help out if you're in the car. Let's see who's great.
Again, we have a good short axis on that aortic valve, and important thing to note is when you're looking for a bicuspid valve, you want to see it open in systole, and so you diagnose that in systole, and so you can see like in the bottom right that when it opens in systole, it looks like the shape is like kind of like a like kind of like a fish mouth opening, which is very suggestive of a bicuspid valve. Also on the top left, the ascending aorta actually looks dilated in this view. I don't think we saw it as well on the transthoracic.
Yeah.
Pretty much.
Particularly that lower left image, particularly for the first-year fellows, you can see what Dr. Ragapati is describing as the fish mouth look. So the aortic valve obviously has three leaflets. It should not open like a fish mouth. This is kind of opening like a bicuspid valve. There's a central opening that looks somewhat like a fish mouth right there, because there's fusion of one of the commissures, and so there's a larger leaflet, smaller leaflet, kind of opening like a fish's mouth. And you can see the Doppler on the lower right going right through that opening with the fish. There's a small amount.
Looking at fusion of the non and the right coronary cusps.
Right. So any of the cusps could be fused. It could be non and right and left, etc. But this is what we're seeing. Okay.
On the Doppler, it looks like so now we're back at the, so this is, the peak gradient is very high, 91, mean gradient of about 55. And looks like we don't see the LVOT profile here, but it's calculated to come out to about 0.6 centimeters square aortic valve area. So it looks consistent with severe AS. It looks like there's some AI as well on that Doppler profile on the right, probably mild AI.
We saw a little glimpse of the AI in the color, but yes. So the peak gradient is quite high, and using the Bernoulli equation for v squared, you can see it's at least 4, which would be 16 times 4. So it's above that. So this is going to be quite high, and they're talking about a peak gradient as high as 9, with a mean of 55. So again, there could be some technical issues with the Doppler and how they draw the lines, but.
Yes, this is a beautiful tracing. It's not contaminated by cycle variability, although the cycles are reasonably longer because the heart rate's 51. So the volume's going to be a little bit greater with each heartbeat given the preserved cardiac output. Nevertheless, this is a beautiful tracing. The contour of it looks, to me, classic. I'm not an echocardiographer. And we would call this right at the cusp of being, I know this is a really sophisticated term, but very severe aortic stenosis instead of severe aortic stenosis, which of course is in fact the term used by the guidelines. And so this is an extra layer of severity. And for lack of a better term, that's what they came up with. Classic, beautiful tracing.
Yeah. So there's kind of this delay. You know, we talk about parvus et tardus, pulses were diminished and delayed. You can see the delay in the velocities coming through that valve, particularly on the top left tracing, I think. So that demonstrates that. And to Dr. Turi's point, the mean grade in here of 55 is higher than the peak very often in valves that were replacing the Syncope.
Especially, as you said, known bicuspid valve, a mean in the low 50s. Peak on transthoracic was high. And then ascending aorta was measured at about 3.6 to 3.7 centimeters, slightly dilated. And then she was 35%. The cardiac surgeons did require the cardiac catheterization, and angiographically normal is expected in such a young patient. And she also had a right heart cath, which showed slightly elevated pressures, wedge pressure of 24, PA pressure 40, mean of 33, suggestive most likely of group 2 pulmonary hypertension from the left-sided heart disease.
So if this were pure aortic stenosis, you would not expect to see these numbers. An RA pressure of 15 is really quite outside the normal for pure aortic stenosis. And while yes, you can have some secondary pulmonary hypertension, this is quite unusual to me.
Yeah. So that's why I pause, because sometimes we pass over these things and say, yeah, that's a right heart cath, great. But I think we should understand all the numbers and what they mean, what they're saying. So with pure aortic stenosis, particularly in a younger person, there's not necessarily a reason that this person should have a high pulmonary artery pressure, and in particular, why they should have a high right heart pressure with an RA of 15 in an otherwise healthy person. So that's a little bit interesting. You wonder if the transducers are balanced properly, or so that's always an issue as we go through this without being deceived.
Yeah, just to comment on the Wood units, it's actually less than 2 Wood units. The wedge pressure here is 24, and PA pressure is 33, so the gradient across is about 9 millimeters, and the cardiac output is 5. So we'll talk about the calculations, but certainly not elevated pulmonary vascular resistance.
Okay, great. Thank you. Let's go forward.
So as the cardiac surgery was consulted, we also got a CT chest, which showed the calcified aortic valve, and it measured the ascending aorta at about 4.2 centimeters rather than transthoracic echo, which had it at 3.7. Regardless, she was given the option of mechanical aortic valve versus valve prosthetic. She actually took a day or two to decide on that, and then eventually ended up deciding on the mechanical valve, and she underwent minimally invasive aortic valve replacement with 21 millimeter onyx mechanical valve.
So that's somewhat interesting. I think before we move off of this, we should chat about that a little bit. So, of course, you know, it's a bicuspid valve, young person, it's a good surgical candidate. So you're thinking open surgery here. The question is, should it be a mechanical valve versus a bioprosthesis? Of course, in the older days, there was no question it was going to be a mechanical valve, because this person has to go another 40, 50 years or more with this valve. So you'd want a durable valve, so that's a mechanical valve. Of course, that requires warfarin. Even the Onyx valve requires some degree of anticoagulation warfarin. So the question is, which valve to choose? Like I said, in my older days, it was always a mechanical valve. I have patients who are still alive with those mechanical valves now 30 years later and doing great with them. But today, because of TAVR and other issues, sometimes we choose a tissue valve, because then you can go back at a later time if there's a problem with that tissue valve and replace it that way. Whereas this one won't need another surgery, but she's going to need, 30, 40 years of warfarin.
So I want to ask a quick question, because I missed the beginning. How big is this gentleman or this patient?
It's a lady.
Lady, I would say she was about 150 pounds. Not big.
How tall?
And I would say low fives, 5.3, 5.4.
The smaller,
Okay.
she's getting a 21 millimeter on it. So tell us why
Yeah.
you asked me that.
So I think Perry, you and I are thinking about the same thing. So relatively small person, this may be okay, but you are looking at a lifetime of needing some kind of a prosthesis. And you really want to worry now about a prosthesis patient mismatch potentially. So the Onyx has pretty good characteristics, but bigger is better. And minimally invasive usually means they can't do an aortic root reconstruction. This patient has the enlarged aorta of bicuspid aortic valve, so that may come in the future as an important issue. But the first thing I would be concerned about is this valve big enough for this patient's body surface area? And there are ways in which you can just basically do the arithmetic. What's the annular size? What's the size of this prosthesis divided by the body surface area to make sure that she doesn't have a gradient post-op, because they frequently do with smaller valves, and it does play a role later. It depends on how old they are. So the guideline, I'm sure there's a talk coming up, so I don't want to take that over. But so the guidelines have changed. It used to be a bioprosthetic when patients are over X age, 60 years, down to 50 years now, and has been moving down further with an idea of what's the next procedure when this valve fails. With a female, you always worry, of course, about the need to anticoagulate and any future pregnancies and so on, depending on how old she is. So I don't know. We are going more and more toward bioprosthetic valves, but the issue would be minimally invasive versus root enlargement if you're going to have to put a small valve in.
Yeah, so you read my mind. You touched on all the things that I wanted to talk about. Yeah, you have to consider a lot here. So, these cases seem simple. This is a 5-minute presentation, no problem. Bicuspid valve gets a new valve. Everybody's happy. But you have to think about the consequences of every decision you make in medicine. So that 4.2 centimeter dilated ascending aorta is potentially problematic because she's 35 now. That could expand. That means I have to go back into chest at a later time to replace that potentially. That's something to worry about. And then the size of this valve is a 21 millimeter, which for the new fellows is very small. The diameter of that valve is small. And so the true area or orifice is smaller than that. And sometimes you end up with a significant gradient across the prosthetic valve, and is not enough flow for the size of the body. So that's this mismatch that Dr. Turi is speaking of. And with the 21, you definitely have to worry about that. The other side of this equation is if you put in a bioprosthesis, a tissue valve with plans for TAVR in the future, you're not going to get a big enough valve in there to put a valve in valve. So it's a problem all the way around with a small aorta, small aortic root. Sometimes they have to enlarge the root. I've done that with patients where the root is enlarged so you can put a big enough valve in so they don't have a mismatch. And you could potentially go back later and do put a valve in valve the actual tissue. But this was the consideration, and of course the surgeons knew all that, and they made their best judgment that the 21 millimeter Onyx valve had the best overall characteristics for this patient. But that valve does require anticoagulation. So at what size ascending aorta in a bicuspid valve do you replace it at the same time as surgery, Doc? Do you have any comments on that?
I think the numbers are, can you hear me?
Yes.
Yes.
Okay. I think the numbers are really pretty similar to what you would do for any patient with an enlarged aorta, unless there's a family history of dissection. But as far as the issue of mismatch, there are many people out there who believe that the aortopathy of bicuspid aortic valves is a significant risk factor for aneurysm and dissection, and would favor replacing the ascending aorta at the same time as the valve. And if you do an entire root replacement with coronary reimplantation, you can pretty much pick a much larger valve than the one that this patient is forced to, instead of having a 21, you could put in a much larger valve if you needed to, if you did an entire root replacement with coronary reimplantation, because your valve would be above the native annulus.
Yeah, Doug, with the in the setting of bicuspid aortic valve, as this patient has, the standard for replacing the aorta is in fact lower, right?
A little bit. It's maybe like half a centimeter. Like normally we would say 5.5 is the number for someone who's just got like hypertension and ascending aneurysm. So, for something like Marfan's, you might want to go down to 4.5 or 5, depending on whether or not there's also family history dissection. But yeah, probably for a bicuspid, I would probably go down to 5.
Yeah, I think that's my point in pausing here is that this is getting, somewhat worrisome. Again, this is not a gigantic person. It's a 5 foot tall, female with a 4.2 centimeter aorta. It's close. In Marfan's at 4.5, we would be concerned. So I am concerned here, but again, the best judgment was made by the clinical team. It's below 4.5, but this lady may come to aortic root surgery or SME aorta surgery at some point in time.
And I like indexing the aortic diameters for height rather than body surface area.
Yeah.
So if this is a short person with a 4.2, that's like a taller person with close to a 5.
Yeah. So I think it wouldn't be crazy to consider doing the root at the same time here.
Perry?
Yes. Oh, hi, Kathleen. Go ahead.
It's Kathleen. There was a long discussion. I was the clinical person at the time. There was a long discussion with the patient about what kind of valve, and really the guidelines still say bioprosthetic, and she was just pretty sure she didn't. I'm sorry, the guidelines still say mechanical. Sorry, mechanical. But she was pretty sure she did not want another operation. She wanted to have one and done. She didn't want to go back for a TAVR, didn't want to go back for a second operation. So that's ultimately why she chose to go with the mechanical.
And that's very helpful. And I think that's reasonable. I don't think anybody would say that's unreasonable. That's very reasonable to have a mechanical valve. That's the way it was always done. And she'll have good durability with this valve. It should last really her lifetime. But
how old is she?
Is the warfarin. Sometimes you get into trouble with that.
Can I ask how old she is? I'm sorry, I missed it.
35.
Okay. Yeah, I mean, the idea that she's one and done, with regard to the valve, may be true, but I would find it hard to believe that with that aortopathy, this lady's not going to have another operation at some point.
Yeah, but
I understand I don't disagree with the logic of the decision that was made. I'm just saying that I would be surprised if she was a one and done with with a life expectancy of 4 or 5 decades ahead of her.
So time will tell, and we obviously won't have that case to look back on, 50 years from now. But from experience with other patients, I've had some that have gone on to be replaced later on. They didn't choose to do it at that time, but the surgeon didn't want to. But many of them never needed replaced, and she may be. But at least for the fellows, we have a discussion that's a worrisome thing. Think about that. Okay, well, let's move forward. What happened?
So post-op, initial 2 days, she did well. Then she was noted to have this on the EKG. Here.
So it looks like a sinus rhythm, but the P waves are kind of marching through, and it looks like there's probably high-grade AV block here.
Yeah.
With junction with a ventricular escape rhythm. It's the right bundle morphology. So she's developing post-operative heart block. What day is this?
This was post-op between post-op day 3 to 5. She would have this intermittently and more progressively more often.
Yeah, you wonder if this was present preoperatively because she did have syncope. Of course, the syncope could have been from the valve itself, from the aortic stenosis, or this could be surgical. And she should likely see EP and may need a pacer here. It looks like.
Yeah. So she's got what appears to be complete heart block, and you can tell that because the P to P interval is through at a different rate than the R to R interval. So the R to R intervals are all constant, and the P to P intervals are all constant, but they don't line up. So this looks like complete heart block with a wide QRS, which was not present. We saw, if you remember back, the pre-op ECG was very normal intervals, normal QRS duration. So this is a change. which is disappointing actually in a young person. Looks like she's going to need a pacemaker. Let's see what happens.
Yeah, unfortunately for someone who really wanted to avoid further interventions, she did end up, getting EP consult afterwards. She was recording a lot of epicardial pacing. As you said, the rhythm showed complete heart block with junctional escapes. I ended up getting a dual chamber pacemaker a couple of days later. And
yeah. So again, we chalk these things up. When I do these conferences, I think we have to have a discussion about the clinical decision and what went on. So everybody kind of sits back in their chair and says, well, yeah, it's aortic valve surgery, the pacemaker. But actually, if you look up the incidence of pacemakers with bicuspid aortic valves, it's low, about 3 to 5%, 5% there, high. Several studies have looked at that. So it's not common to need a pacemaker after this type of surgery. But in this case, there must have been a lot of calcification in the conduction system, I suppose. But we shouldn't come to think that everybody with an aortic valve is a pacemaker. The TAVR world, it's a little different, but this is the surgical world where they can see what they're doing. They're not pressing things into the, into that area like with TAVR under pressure of a balloon. They're actually surgically excising that valve. So not common. About 95% of the time you wouldn't expect a pacemaker, but this is one. Okay.
And she did relatively well in the PCU service afterwards. Was discharged on aspirin and warfarin for the mechanical valve, and she's been following very closely with Dr. Hines.
So let's just we're really at the end of the case, but I'm just curious, why aspirin and warfarin? Dr. Hines, why aspirin and warfarin?
The guidelines still say with a mechanical valve on warfarin should also be on 1 baby aspirin a day.
Yeah. Okay. All right. So she's on a low dose aspirin, warfarin. What's the INR you're shooting?
So with the Onyx valve, for the first 3 months, 2 to 3, but after that, 1.5 to 2. So you can run the INR a little bit lower. And interestingly, her daily dose is about 2 milligrams a day. So, it's really hard to predict, but she's somebody who takes a very small dose and it's therapeutic.
So that's great. Thanks, Kathleen. The Onyx valve has these particularly favorable characteristics. So they're approved for INRs 1.5 to 2.0, as opposed to other valves where it's 2 to 3 in the aortic position. So this is 1.5 to 2, which may be a slight advantage, slightly lower